So I'm Steve Nissen, Chair of the Department of Cardiovascular Medicine, and I'm here today with two of the world's experts in hypertrophic cardiomyopathy. On my far left, Dr. Milind Desai, who's a cardiologist, and immediately to my left, Dr. Nick Smedira, who's a cardiac surgeon with really extraordinary experience with surgical treatment of this disorder. So, gentlemen, you're seeing a lot of these patients. Is this growing in incidence, or are we just becoming better at recognizing it?
I think the short answer is I think we are getting better with our advanced imaging techniques at predicting and recognizing these patients. And once you identify an index patient, then we are diligent about screening their first-degree relatives and their first-degree relatives. So we are picking up a lot more than what we were in the past.
Yeah, and I want to circle back later and talk a little bit about what we should do about family members of people with the disorder. So how do they generally come to attention?
So often, the way these guys present is they have somebody hears an incidental murmur. Occasionally there is symptoms. Then people ultimately connect the dots. Often they get to us in a circuitous way where somebody's made a misdiagnosis for years, and then you look at an EKG, look at an echo as part of some symptom workup, and then you come across, oops, this could be hypertrophic cardiomyopathy. Often they are family members of other affected members, and they are coming to us for screening. So they come to us in various different ways.
Now, are there definitive diagnostic criteria? So to say to somebody, you definitely have hypertrophic obstructive cardiomyopathy, what do you need to find to say that?
So if you read the books, if you read the guidelines, the definitive criteria is unexplained hypertrophy in the setting of either a family history and no other real reason that can account for that level of hypertrophy.
And how much hypertrophy do you require?
So severe. So 15 millimeters in the wall thickness is typically considered as hypertrophic cardio, or anything beyond that, especially when you have no real reason, so no long-standing hypertension or something else that can account. Having said that, Dr. Smedira and I, we have devoted at least for the last decade in identifying, or rather challenging, the notion that for you to have hypertrophic cardiomyopathy, hypertrophy is necessary. We have a substantial group of patients, atypical presentation, where they have the HCM phenotype, but they're missing the H. We call them the OCM without the H.
Well, so what do they have, Nick? Are they obstructive?
So I think there's two things to think about. One is the muscle. Do they have thick muscle? Mm-hmm. And then if you have thick muscle, do you have a genetic disorder?
Yeah.
But physiologically, all that really matters to the patient is there a problem with the blood getting out of the heart?
Yeah.
Is there a challenge when the heart is working hard that the blood can't get easily out of the heart and often goes back into the lungs? And you do not need wall thickness or hypertrophy to make that happen. I think that is one of the interesting and unique findings we have proposed to cardiologists around the globe, is that you do not need significant hypertrophy to have challenges with the blood getting out of the heart.
So what you're saying is, if you have obstruction,
the way I think about it surgically is you have a path for the blood to get out of the heart. One half of it's the septum, where thickness can, and the other half is the mitral valve. And traditionally we think the whole problem is the septum of hypertrophy. And what we're finding in really phenomenally interesting cases is you can have a genetic disorder predisposing you to hypertrophy or thickness, have no thickness, and yet have obstruction because the mitral valve is the primary cause of it. So we think of it holistically, look at the channel or path for blood to get out of the heart and determine what are the relevant components of that.
Do they always have mitral regurgitation?
No. I don't think so.
No,
Yeah.
not always.
Yeah,
I
yeah,
mean, and like Dr. Smedira said, every patient tends to be different. Even within the same group of cluster families of affected individuals, you may have different presentations. So some of them may have thick heart muscle, thus thickened septum. Some of them may not have thickened septum. It may be in the apex, it may be in the lateral wall. A lot of them, not all of them have abnormal mitral valve morphology. So while it is very frequent, so a lot of times, especially in the obstructive cases, what you have is some level of hypertrophy that basically causes turbulence to the flow of blood getting out, which tends to suck in the mitral valve, what we call systolic anterior motion, or SAM of the mitral valve. That can lead to a specific type of mitral regurgitation. Very common.
So let me understand this now from the surgeon's perspective. I mean, Nick, you probably how many surgical procedures have you done on people with HOCM?
Well over 2,000, probably
Okay.
approaching 2,500.
Probably as many as anybody in the world, maybe more.
Yeah.
So is there one surgical approach, or are there many surgical approaches?
Well, the most common surgical approach is what we call a septomyectomy, and in its technical aspects, it's pretty simple. You cut a certain thickness out of the septum to thin it to get to what we hope is normal thickness.
Yes.
But the challenge is the septum is a three-dimensional structure with various thicknesses, both from left to right and from front to back or base to apex. So the real challenge for the surgeon working inside the chamber of the heart is to be able to focus the removal of the muscle where it needs to be.
So how do you guide that? How do you figure out how much muscle to take off at various
And
levels?
Where do you do it?
Yeah.
Yeah, this is where the collaboration with imaging specialists really come into to play. And I have learned a great deal in the operating room from a cardiologist initially who did the transesophageal echo, and now my anesthesiologists who are trained to do that. And we spend a great deal of time in the beginning of the case mapping out by transesophageal echo septal thickness in multiple different quadrants. So I have a three-dimensional image in my brain to go in there and know where to go. Now, having done a couple thousand helps you understand the anatomy because you learn pattern recognition and you're able to respond to it. But it's the collaboration with the imaging specialists and then the experience that leads to the ability to take it out right where it needs to be.
Now, what if they have the obstruction but they don't have the septal hypertrophy? What do you do about those people?
So it's a very interesting historical study because there was a debate back in the 60s and 70s when we were starting to do the muscle resection. A very famous surgeon by the name of Dr. Cooley would say, you don't have to do a myectomy, watch me do a mitral valve replacement in about 10 seconds, and he'd do a quick mitral valve replacement with mechanical valve. And the idea is with the two components, muscle and valve, if you take out half of the mitral valve and replace it with an artificial valve, you will get rid of obstruction.
Yes.
You can leave the muscle alone. Our preference at the Cleveland Clinic has always been maintain your own valve repair. So we began to look very closely at the physiology and pathophysiology of obstruction related to the mitral valve. So things that we've seen is the leaflet can be very elongated, so there's techniques to shorten the leaflet. We see that the papillary muscles, which often should be below what I call the equator of the ventricle, can be abnormally oriented, and we have techniques or developed techniques where you can reorient them. And last resort, which I always talk to patients about, is if I can't fix it, then we would need to replace it. And that is a cure, but you're left with an artificial
Which has its own downsides.
downside.
Now, how do you decide, the two of you, how do you decide who gets operated on, who gets treated medically?
So, the standard thought process is you treat the symptoms with medical therapy, like beta blockers, or in some cases calcium channel blockers. In rare cases, disopyramide, because of its side effect profile. And you push the medications till they reach a situation where the medicines are giving them side effects or tremendously affecting their quality of life. And then we offer them various options. A lot of times what we end up seeing is that these are younger patients in their 30s and 40s, and they are loath to taking very high doses of beta blocker for its various side effects. And we are blessed to be in a place where we are, where I have excellent surgical collaboration. So, if it is affecting their quality of life tremendously, then we discuss various options. And if the anatomy is suitable, the patient is willing, then we would, after a trial of effective medical therapy or ineffective medical therapy, we proceed with surgery.
So in terms of prognosis, so if you take the kind of people come in the door that have a pretty severe, obstructive, cardiomyopathy, you give them medical therapy, what % of them actually get better?
In our experience, again, we are a large tertiary care center, so we don't see the full spectrum. We
You
do
see
see
the
the
more
full
severe
spectrum.
patients.
We often see more severe patients that get referred from outside, but eventually, in my practice, I can tell you, less than 50% people who I would have been following for 5 years, they remain. More than 50% patients will progress enough to be referred for surgical therapies.
Yeah. And with the surgical outcomes, how well do people do? Is everybody get better? Do most people get better? What's the prognosis?
The vast majority of patients are what we call functional class 1. It's the most rewarding operation I do. The Christmas cards I get, the pictures of people climbing in the Rockies, or pictures of them playing baseball with their kids, occur with septal myectomy more so than any other operation I've done. You materially and significantly impact their quality of life. And our data, the Mayo Clinic data, other data shows that if you take folks that have undergone a septal myectomy and you match them to the age and gender matched U.S. population, their survival is no different.
How about the incidence of sudden death? Can you reduce the incidence
So
of sudden death?
that's an interesting conversation, Steve. Traditionally, if you look at surgical myectomy, everybody's talking about symptom relief. How, I was not able to climb a flight of stairs, now I can play a full baseball game, that kind of thing. Not too many people, and the dogma is, one is symptom relief due to outflow tract obstruction, the other is prevention of sudden cardiac death, which is where a whole, you put an defibrillator for primary prevention or secondary prevention, and there's various factors people look for to classify them as high risk. What we have shown most recently in a paper in JACC a few months ago is we took almost 1,400 patients, all of whom had a cardiac MRI. We quantified all kinds of things, including the amount of myocardial fibrosis they have. What we were able to show when we divided patients into different groups, so low amount of scar who did not have a myectomy, low amount of scar who had a myectomy, more importantly, high amount of scar, and there was a group where we did not seem the need to undergo myectomy versus the other group. So what we were able to show is that surgical myectomy was able to modulate down or significantly reduce the risk of sudden cardiac death or appropriate ICD discharge. So this is, I would say, provocative data where we are challenging the notion that, they are not two parallel tracks that don't intersect. Sudden cardiac death and outflow relief, symptom relief could intersect. And what myectomy does is it debulks a lot of the septal muscle. Septum is where, or the thickened muscle is where there's a higher amount of scar. So it is our belief that it offers us a twofer, basically.
Makes them feel better,
Yes.
and makes them live longer.
Make them live longer by removing some of the diseased muscle where there's a lot of scar. And scar also has been associated with higher risk of sudden cardiac death. So the answer is, I think, this needs to be replicated in other centers, etc. But our belief is that myectomy helps modulate symptoms as well as outcomes.
And one of my approaches have been to do a very extensive myectomy, and I look at it on a volumetric basis. The original description by Dr. Morrow was to take a very somewhat narrow strip, but deep strip of muscle from the center of the septum. And my technique is to go very wide across the entire breadth of the septum and to go as far as I need to.
Get that scar out of there.
Get everything out of there. It also, I think, and if you look at the published series, the weight of muscle I take on average per myectomy is twice of what other people have published in the past. So it could be that approach has somewhat mitigated some of the risk of sudden death, although it's really down.
And to your previous comment about, the communication, we diligently look at every echo, every stress test that we do. And a lot of these folks also have a cardiac MRI. And, every time I see a patient like this, I'm looking at it. And if I recognize something out of the ordinary, almost 100% of the times, I will either, at the very least, I send Nick and my colleagues in CT surgery an email, but most often I will walk up, we will review the images together so that there are no surprises in the OR. If Nick is surprised in the OR for some unfortunate reason, then I have not done my job. So we are very...
Did these people all have myocardial fiber disarray, or is it more than one disease here?
So so we are presenting some data at AHA in literally 10 days, or where we have looked at almost 2,000 odd surgical myectomy specimens, and we have diligently looked at the pathology of those folks. As it turns out, the experienced clinician, Nick or Harry, any one of us look at these and say, this person is hypertrophic cardiomyopathy, symptomatic enough to need a surgical myectomy. You do the surgery, and then we get the pathology, we look at it under the microscope. Only about 80% have the traditional description
Morphology.
of morphologic or pathologic,
Histopathologic.
HCM changes.
Yeah.
Some of them have. We were pleasantly, we were surprised as to what the spread of the other.
Is amazing.
It's not one disease, is it?
No.
No, so let's talk about, in our final few minutes, let's talk about the genetics. And how is this inherited? What do you do with family members? What do people need to know about if you have somebody in the family that's had this?
So this is thought of as an autosomal dominant disease. The prevalence is about 1 in 500, but that can be questioned or challenged. This is the disease where there's lots of genetic discoveries made. There's more than 10 genes and a lot more mutations that have been identified in the myocyte, the myofibrils and chains, etc. The problem is if you take an unselected population of hypertrophic cardiomyopathy, consecutive groups, and if you take about 100 patients that we clinically feel have HCM, and then you do genetic testing in all of them, the yield of gene positivity is about 30 to 40%.
That's high.
That's high, but it's not
50%.
or it's not a lot higher. So the way we handle it is if I see an index patient who has hypertrophic cardiomyopathy, we always offer them genetic counseling. We always recommend that their first degree relatives be screened. And then we can take a couple of different approaches. If you are gene positive as an index patient, then I would recommend that the first degree relatives have blood tests for that specific gene. If they are negative, then they and their downstream generations are absolved. If you are positive for gene, then you need to look for the phenotype.
And you got to then repeatedly do echoes
Yes.
and look for this. And if they develop the syndrome, then you go through the algorithm that you've described.
Exactly. And then there's about 60+% patients where you have the index patient has the appearance of HCM, but they're gene negative. Unfortunately, their first degree relatives, genetic testing is not going to help. at least the modern current genetic. And you need to continue with echo and screening.
How often do you do an echo?
3 to 5 years.
Okay. Well, thank you both for bringing us up to speed on this fascinating disorder. You've heard from two of the world's experts and really the pioneers in the contemporary treatment of hypertrophic obstructive cardiomyopathy. And thank you for joining us.
Thank you.